After covering the anatomy of the pituitary gland, now let's talk about the dysfunctions of the various dysfunctions of the pituitary gland. First being the posterior pituitary dysfunction. Now we know that the posterior lobe of the pituitary, or it is also called as the neurohypophysis, so it is actually a storage site. The posterior lobe is actually a storage site for the hormone produced by the hypothalamus. So it is not actually a gland. We know that the anterior pituitary is the main gland, whereas the posterior pituitary is more of a storage site for the hormones that are produced by the hypothalamus. And in the hypothalamus, the supraoptic and the paraventricular nuclei are the areas where these hormones are synthesized. Now the posterior pituitary produces oxytocin and antidiuretic hormone. Now what does these hormones do? The oxytocin, first of all, the oxytocin, it causes uterine contraction during labor, and it also uterine contraction during labor, and it also causes release of the milk during suckling response. Now when the baby suckle the nipple of the mother, so what happened that the oxytocin is released, and that oxytocin causes the release of the milk. Okay, now there is also one another hormone that act on the milk, and that is a prolactin. The prolactin causes the stimulation of the breast to produce milk. So you have to differentiate in between these two. Oxytocin causes the release of the milk, whereas prolactin causes the production of the milk. It stimulates the production of the milk. So that's all about the oxytocin. Mainly two functions. One is the contraction during labor, and second is the production of the milk. Second is the antidiuretic hormone, which is the main hormone over here that is produced, and it acts on the distal convoluted tubule and the collecting ducts to retain water in the body. So it acts on these areas, the distal convoluted tubule and the collecting ducts mainly. So uh, it acts over there, and it causes the reabsorption of water, and that's why it causes the decreased urine. So it causes a decrease in the urine volume. That is why it is called as antidiuretic. That it is against diuresis. Diuresis is the process of urination, a process of production of urine. So it decreases the urine volume. Antidiuretic hormone, that's why it is called as. A little bit about its physiology. We know that there are two receptors on which it may act. It acts. These are V1 and V2 receptors. The V1 receptors are present on the vascular smooth muscles, and as a result, what happens that once it acts on these, it causes vasoconstriction, and that vasoconstriction is due to the calcium influx, and thus it causes the raise in blood pressure because the smooth muscle contraction occur. So vasocompression or vasoconstriction once occur, it causes a rise in blood pressure. The second receptors that are V2 receptors that are mainly present in the on the basolateral membrane of the distal convoluted tubule and collecting ducts. And once these receptors are stimulated, what happens that these receptors which are present on the basolateral surface, they causes the aquaporine, which are proteins present in the within the cells. So these aquaporins are then translocated to the apical membrane. Apical membrane is the luminal membrane to absorb more water. So thus it causes the absorption of the water. Over here, if I may draw the membrane, and if these are cells, so this over here is these, suppose these are the cells. So on this side, this is the basolateral membrane, whereas the luminal surface of the membrane, that is called as the apical membrane. So in the apical membrane, the aquaporins are translocated, and from here they absorb the water from the lumen. Okay, the now one of the other interaction is that the V2 receptors are also present on the vascular endothelium, and what will happen once these are stimulated, so they causes a release of the von Willebrand factor and factor 8. So these factors will also be released, and that's why you will see that the ADH analog are also used in von Willebrand disease as well as in hemophilia. In hemophilia, the factor 8 deficiency is there, so once you give ADH receptor agonist such as desmopressin, so it will causes a release of factor 8 from the vascular endothelium. But let's just focus on the pituitary. So pituitary, the posterior pituitary produces oxytocin and antidiuretic hormone. Oxytocin help in labor as well as in the suckling response, whereas ADH helps to retain water. Now we will talk about the first dysfunction that we have, the important one, that is the diabetes insipidus. Okay, so diabetes insipidus, now it is a condition that is characterized by inability to produce concentrated urine due to ADH dysfunction. So the person is unable to produce concentrated urine due to the ADH dysfunction. That is, the ADH is either deficient in quantity or it may not be stimulating its receptors. So that is the ADH dysfunction. So as a result, what will happen, that lots of water will be lost in the urine, and as a result we will be unable to produce concentrated urine. Diabetes, as you know, the diabetes mellitus, which is the main diabetes, so that causes polydipsia, polyuria, and polyphagia. So that diabetes mainly over there is related with the frequent urination or polyuria. So over here again you will have polyuria, but it will be due to the ADH deficiency or ADH dysfunction. Now the diabetes insipidus is of two types, the central and the nephrogenic diabetes insipidus. So we will cover each of these in detail now. First of all, we will talk about the central diabetes insipidus. So it is a condition that is characterized by inability to produce concentrated urine due to the ADH deficiency. You have to remember this. It is due to the ADH deficiency that is caused by hypothalamic or pituitary pathology. So since ADH is produced by the hypothalamus and then it is stored in posterior pituitary, so these two pathologies, once there are pathologies in these two, so it will lead to the ADH deficiency that will then in turn causes central diabetes insipidus. Now what are these pathologies? Maybe it may be head trauma, it may be inflammation of the hypothalamus, it may be tumor of the hypothalamus, such as the craniopharyngioma. So craniopharyngioma is actually a hypothalamic supracellular tumor. So it then causes, once this tumor is there, so it causes compression and it won't allow the hormones to pass through. Moreover, there is Wolfram syndrome. So Wolfram syndrome is also known as Didmore syndrome. Okay, so this syndrome actually comprises of the diabetes insipidus, diabetes mellitus, optical atrophy, and deafness. So all these combine form the Wolfram syndrome. So these are the various different causes of the central diabetes insipidus. But the thing to remember it is that this is caused by the ADH deficiency. There will be deficiency of the ADH, and once we come to the lab you will see that the ADH level in these patients will be low. Now let's come to the nephrogenic diabetes insipidus. So nephrogenic diabetes insipidus is again a condition, inability to produce the concentrated urine, and it is due to the resistance of the distal convoluted tubule and the collecting duct to the ADH. That was due to the ADH deficiency, the central, whereas the nephrogenic diabetes insipidus is due to the resistance of the distal convoluted tubule and the collecting duct to ADH. It may cause some, it may be due to some inherent mutation or some drugs such as lithium, demeclocycline, sorry about that. So some drugs such as lithium, demeclocycline, or it may be some due to conditions such as hypokalemia, hyperkalemia, or nephrocalcinosis. So these are the various conditions that affect the kidneys, and as a result the kidney is unable to respond to the ADH, and as a result what happens that the nephrogenic diabetic insipidus occurs. Now the clinical features of the diabetes insipidus. So you know what will happen, that you will have, since antidiuretic hormone is absent, so what will happen that you will have frequent urination, and that is called as polyuria, and since you are losing a lot of water, so there is a risk of life-threatening dehydration. There is low urine osmolarity. The urine osmolarity due to the dilute urine, you are losing a lot of water, so what will happen, this will cause dilution of urine, and this dilution of urine is called as low urine osmolarity and specific gravity. So urine specific gravity will be low. Moreover, there will be high serum osmolarity. Urine osmolarity will be low, but the serum osmolarity will be high. So there will be high serum osmolarity and hypernatremia. The sodium osmolarity will also be high. So, and this will be because the water is lost. So as a result, what will happen, that there will be buildup of the sodium and electrolytes in the blood.
Okay, so high serum osmolarity and low urine osmolarity. The high sodium in the blood, that will the hypernatremia, that will causes polydipsia. Polydipsia is that you will be excessive thirsty, and moreover it will also lead to neurological manifestations such as confusions, disorientation, and seizures, etc., due to the the sodium is mainly responsible for the transmission of impulses. So the whole nervous system will get a lot of neurological manifestation will occur, and that will lead to the confusion, disorientation, and seizures, etc. Now, the diagnosis of the diabetes insipidus, how you will diagnose the patient. So first of all, always remember, to diagnose a patient, follow the general order, that is history, examination, and then investigation. So the patient will have history of the signs and symptoms, and on examination you will have the signs of dehydration. So dehydration, that is mainly you can do by skin pinch test. Okay, or the patient may be showing some confusion or the signs of hypernatremia. The investigation, what you will do now, first of all, you will do ADH levels, and we know that ADH level will be low in central diabetes insipidus and high in the nephrogenic diabetes insipidus. In the central it will be low because the hypothalamic pituitary axis is disturbed, and as a result ADH is not produced. In the nephrogenic diabetes insipidus, what happened that the kidneys are not responding, so as a result the pituitary and the hypothalamus are trying to make them respond by producing more and more of the ADH. So as a result there will be high ADH in nephrogenic diabetes insipidus. Moreover, the urine osmolarity, it will be decreased in this patient. In the diabetes insipidus patient, the urine osmolarity will be low. That is because you are losing a lot of water, so your urine will be diluted. Moreover, the serum osmolarity will be high. That is because since water is lost, so there is build up of the electrolytes. There will be hypernatremia. Now, the main test that you do, that is the water deprivation test. So it is a two-stage test in which the patient is deprived of water, as the name indicates, water deprivation test. The patient is deprived of water for 8 hours initially, that is its first stage, and then we see that whether the patient is what is his response to this dehydration, that whether his kidney continue to produce the dilute urine. If it is continuously producing dilute urine, that shows, that confirms the diabetes insipidus, that ADH is not released or ADH is not functioning. And then we once we diagnose that this is diabetes insipidus, then to differentiate that whether it is central or nephrogenic, then we find the cause by giving the patient domperidone. So once the domperidone is given, it is ADH analog. So domperidone, desmopressin, I think that is desmopressin. So that is given, and then you will find that whether sorry about here it is not domperidone, it is desmopressin. Okay, so desmopressin is actually the ADH analog. Desmopressin, I hope you know it. Okay, so desmopressin is the ADH analog that will be given to this patient. Okay, now first of all, now let's talk about this test in detail. First of all, to confirm that whether it is diabetes insipidus or not, so first of all you will empty the bladder of the patient at some specific time. Then after that, no drink will be allowed to him, and only dry fruits will be given to the patient. Then the serum and urine osmolarity will be checked, will be monitored every 2 hours for about 8 hours, and the patient weight is also measured, and the test is stopped if the patient loses greater than 3% of his weight. Now, how will you interpret the result? If in a normal person, what will happen, that the osmolarity of the urine osmolarity will be raised. Why it will be raised? Because you are deprived of water. So what will happen, that the that very small amount of concentrated urine of about 600 milliosmol or greater than 600 milliosmol per kg of the urine, a concentrated urine will be formed with very little water in it. Okay, and thus you will have a normal serum osmolarity of 275 to 295 milliosmol per kilogram. However, in patient with the diabetes insipidus, what will happen, that they will fail to concentrate, because for concentrating urine, concentrated urine, you need ADH to function. Since ADH is not functioning, what will happen, that the urine osmolarity will be less than 600 milliosmol per kilogram. Hence water, since water loss occurs in these, so what will happen, that the serum osmolarity will raise to about 300 milliosmol per kilogram. Now there is another type of diabetes insipidus, that is called as that is not actually diabetes insipidus, but that is called as psychogenic polydipsia. And the psychogenic polydipsia is a polydipsia that is characterized by excessive fluid intake in the absence of the physiological stimuli to drink. Okay, there means the patient are just psychic to take more and more water. Okay, so the urine concentrates but less than normal. In these patients the urine will concentrate but less than normal, so that is, it will be greater than 400 but fewer than 600 milliosmol per kg. This is the normal. Greater than 600 milliosmol per kg is the normal, is the concentration in normal patient. Okay, so in these there will be between 400 to 600. Serum osmolarity is low at the start of the test because they are taking a lots and lots of fluid. Now that was to find out that whether the patient is having diabetes insipidus or not. Now let's try to differentiate between that, whether this diabetes insipidus is central or nephrogenic. For this you will give 2 microgram intramuscular desmopressin. Now desmopressin is ADH analog, that is, it works just like ADH. So what will happen, that if the patient respond to it, that if the urine is concentrated after giving this, so what will happen, that it shows that the kidneys are responding to ADH, so it is not a nephrogenic. So which diabetes insipidus it is? It is a central diabetes insipidus. On the other hand, if the urine failed to concentrate even after giving ADH analog, so this shows that the kidneys are not responding to ADH, hence this diabetes insipidus is nephrogenic diabetes insipidus.